Part of this talk on being misled by trials is happening now, but some of it will be continued as the conference starts, since Gordon will be dealing with this issue, but we've tried to eliminate any sort of overlap, and so you'll see I'll be pointing out where the overlap would have been, and that you will get the second part of this tomorrow. This slide also has my email address, and I welcome your comments and email, as well as my Twitter handle. If somebody is on Twitter, feel free to comment on Twitter as well. So if the purpose of evidence-based care is to take care of people, it means we need to move from having a deep understanding of the patient's situation and what aspect of that situation requires us to act, and what action corresponds or best addresses or meets those demands. That work that we have to do to identify the patient's situation and then respond appropriately is work that draws from having understanding of our own experience, the experience of the patient that we're working with, the values of that patient, the recommendations that may be pertinent to that action, and of course, the evidence that we can draw from to try to understand how to proceed. However, evidence may fail us, and evidence can fail us in a number of ways, and these are four central ways in which evidence can fail us. Bias, and we've discussed this morning, spin, which we'll be talking about now, biased reporting, which is when the evidence that we think we know is only a partial representation of the evidence that is, and of course fraud, which is fortunately still very rare, and not something we're going to be discussing today. So to talk about spin, the User's Guide to the Medical Literature offers seven guides to understanding spin. One of them, reading the methods and the results and avoiding the titled introduction and discussion section, will be discussed by Gordon tomorrow, along with reading pre-appraised resources. But there are others here, like beware large effects in trials with only a few events, beware faulty comparators, we'll talk about that today, beware small effects and extrapolation to lower-risk populations, beware uneven emphasis on benefits and harm, and then wait for the overall results to emerge, do not rush. And we're going to be mostly focusing on the bottom half of this list. So as I point out, these are the ones we're going to be discussing today. So another way of thinking about what we're going to be talking about is that in the work of moving from understanding the patient's situation into action and drawing from evidence to try to respond properly, we could be misled if the evidence appears relevant to that work, but in fact it is not. Appears valid, but in fact it is not. So one of the ways in which that happens is the problem of incomparable comparators. Somehow the psychiatrists do this very well. And so there are 8 trials of antipsychotic medication in which the new generation antipsychotics were compared with very high doses of haloperidol, only to demonstrate the obvious that the newer ones were safer but if you take into account that in clinical practice we will use a much lower dose of haloperidol, if at all, then this comparison is unfair. Or when they compared a new antidepressant with amitriptyline, used not once a day, usually once a night, as it's often done in clinical practice, but twice a day, including 1 dose in the morning, only to report that there was more daytime somnolence with amitriptyline. Well, that seems, again, an unfair comparison, but more importantly, if we don't notice that, it will give us a sense that the newer drugs are safer and therefore should be used to solve the problem of the patient, be it psychosis or depression. Another aspect to talk about now is the problem of small effects. So the small effect is an effect that is where the point estimate is very close to no effect. So in that case, the relative risk reduction or the absolute risk reduction or the money left after you go to have lunch with Roman is close to 0. Or the relative risk or the odds ratio is close to 1. When the confidence interval, the other way of thinking about it is when the confidence interval includes values that are close to these values of no effect. So in these situations, you're dealing with a small effects problem. And as I will point out at the end, These are the situations in which the authors of the papers, those that disseminate the results, will feel most compelled to make those results look bigger or more important than they really are. And that's a situation where you are at most risk of being misled by the presentations of such clinical trials. So I'm an endocrinologist. I mostly take care of patients with diabetes. And I was in the stadium in Barcelona in 1998 when the results of the UK-PDS trial were announced. Up to that point, the idea that lowering glucose was the link between treatment and reduction in the risk of diabetes complications had only been demonstrated in one trial, a very large trial, in patients with type 1 diabetes. The answer was still not in for patients with type 2 diabetes. In the 70s, a trial, a UK-PDS trial, was organized and conducted, expected to last 5 years and demonstrate the same thing as the DCCT trial found in patients with type 1 diabetes. However, after 5 years, no answer. Additional funds came in from the US, from Japan, and other cooperative agencies that added to the funding from the UK for the trial to continue, until eventually in 1998, or soon before that, the investigators were able to find the significant p-value they were looking for more than a decade. In fact, when this trial was presented in the big auditorium, the big stadium, basketball stadium in Barcelona, the first picture that was up was the investigator, Dr. Turner, and when he started the trial, he was a young man versus the very old man that was presenting the results that finally achieved, indicating the enormous personal cost and sacrifice of the investigators of these very large trials. He, in fact, died in, I believe it was New York, as he was on tour reporting the results of the trial. So it cost him, most of his life. So in that trial, they enrolled almost 4,000 patients with diabetes. They followed them up for 10 years. And this, one of the major findings when he announced it, was that they found a significant difference in any diabetes-related endpoint at the end of the trial. When he announced his results, half the stadium stood up, and I thought they were going to clap, but they stood up and left. And they left because they were buying stock of anti-hyperglycemic medication companies that were selling these drugs. And at the time, cell phones were not that common. So some of them were on cell phones, some of them were on payphones trying to buy stock. And next to me was an endocrinologist who was my mentor at the time, and he elbowed me and said, "This is the result we've been looking for," indicating a significant predisposition to believe the results. And this is the breakdown. Intensive therapy, 35.3%. Conservative therapy, letting the blood sugar be higher before intervening, 38.5%. A difference of 3.2%. I think it's a small difference after 10 years and 4,000 patients, and a p-value of 0.03. So this is a small effect. But then when you look at how that effect was achieved, as the investigators were maturing on the trial and not finding an answer, they kept adding components to this composite endpoint of any diabetes-related endpoint. And so they have things that are really important to patients, like dying, but there are things at the bottom, like removing your cataracts. And I would say that for patients, it's a very different experience to die than to have your cataracts removed. I think most of you would agree that these are different experiences. But they were all put in the same composite endpoint. And the last composite endpoint that was added to the list was receiving retinal photocoagulation with laser therapy. Interestingly enough, of the 3.2% difference between the arms, that last component accounted for 2.7% of that difference. So one of the ways in which trials can spin is like, oh, we saw a big difference in any diabetes-related endpoint, including death, heart attack, and stroke. And you're thinking, gosh, if I control sugars in patients with diabetes, all these outcomes are going to reduce. But when you see that the majority of the effect was in laser therapy to the eye, that's slightly different. So how might we break that down? And here are a bunch of questions that you could ask to try to understand results that are reported using a composite endpoint. Is there a gradient of patient importance in the components? Death, cataracts, big gradient. Is there a gradient of treatment effects? Small differences between where one of them, photocoagulation, captures the majority of the effect. And so when we looked at randomized trials in cardiology, we noticed that composite endpoints were used very frequently as the primary endpoint in these trials, and about almost 90% of these failed the first two criteria. There's too much of a gradient in patient importance and too much of a gradient in treatment effects between the components to actually buy the composite as a good representation of the effect of therapy on the patients participating in the trial. Another way in which we can be misled, so for small effects, is to present composites, but the other one is to present the results in different time frames. So we saw that 3.2 fewer any diabetes-related endpoint for every 100 patients with diabetes treated over 10 years. But the same authors reported 2.3 more episodes of severe hypoglycemia. This is low blood sugar requiring third-party assistance for every 100 people, but this statistic is after every year of therapy. So one gets the sense that, my goodness, you get a little bit of low blood sugar, big reduction in death, heart attacks and stuff, when in fact you have a small reduction, mostly in photocoagulation, at the expense of 2.3 more episodes of severe hypoglycemia requiring third-party assistance every year for those 10-year period. So you can see how these could give you a wrong impression of safety. So, what are the things that people do in general? I just give you a couple of examples, but things that people do in general to make small effects look large. One is to use relative rather than absolute risk, to express risk during a long period, for use like we saw with the 3.2% after 10 years. Use visual representations where the y-axis is not a 0, but it's much higher. So if they set it up, say, at 60%, small differences at the top between survivals of 100% versus survivals of 99% will look big on the graph, give you a sense of a big result. Include a few high-risk patients in a trial of predominantly low-risk patients, so you get the sense that there's this big effect, mostly captured in the high-risk population, but you're going to extrapolate it or apply it to everyone that satisfied the eligibility criteria, and you could see the majority of those patients are low risk. You might be misled in that way. Use composite endpoints like I show you for the UK-PDS. Ignore the lower boundary of the confidence interval. I show you that 3.2%. I mentioned nothing about the composite endpoint. The confidence interval, but I'll do that in a minute, and you'll see an example of that. And then, of course, focus on the statistical significance and not on the estimate. This is when our language tends to use terms that are black or white, where we say glycemic control reduces the risk of diabetes complications without making a point about to what extent does it reduce, what is the magnitude of reduction. Of course, that's very convenient if the magnitude of reduction is very small. So we've discussed these issues. Now let's going to go to the issue of looking at the overall results. Gordon mentioned at the beginning that at least a couple of the principles of evidence-based practice, one, that there is a hierarchy of evidence, and another one, which we'll discuss at the end of this session, about that the evidence alone never tells you what to do, that you have to incorporate patients' concerns, context, values, and preferences. But a key principle of evidence-based practice is that one has to base decisions not on the latest trial, but on the body of evidence. So here's a result, the body of evidence of glycemic control. At the top, you can see the UK-PDS trial that I was discussing just a few minutes ago. And I've chosen 3 of the outcomes that perhaps matter to most people: all-cause mortality, cardiovascular mortality, and non-fatal MI. And the UK-PDS trials are on the top, and you can see in 1998. There's a gap until 2006 with a series of other trials show up. Those in red are the follow-up of the trials indicated by the same name. And in green are meta-analysis of the trials accumulated and of the follow-up studies accumulated up to that point, including the orange at the bottom, which is the most updated meta-analysis. So if you look at this, the most updated result is that there is no effect on all-cause mortality, there is no effect of glycemic control on cardiovascular mortality, and there is a 15% reduction of due to glycemic control on non-fatal myocardial infarction. And if you had just acted on the UK-PDS, one would have gotten the impression that glycemic control, particularly with metformin, reduced the risk of all-cause mortality. But that's a result that, after considering the totality of the evidence, is not clear. So finally, I'm going to spend the last 4 minutes discussing the problem of acting too quickly. I don't know what the medical culture is in all the different parts where all you come, but I'm from Peru, and it was there was a lot of showmanship. As I was a medical student, everybody wanted to practice medicine on the basis of the latest results, even though we didn't have the resources to actually practice medicine based on the latest results. And in fact, it was wasteful probably to do so. But what are the problems of jumping too quickly at the evidence, at the latest results? In fact, what is the problem of going to many of the subspecialty meetings in which people come in to show you for late-breaking results of their latest studies and then suggesting that you go back home and apply them right away? This turns out to be a very dangerous practice. Why? First of all, because early studies may actually have sources of bias that you may want to uncover when the trial is fully published or only become evident after a while. And maybe later studies correct those sources of bias and maybe provide a much more balanced result. There's problems also of reporting bias and dissemination bias, by which the results that are positive and spectacular will make it to the press, that be the lay press or the medical press, faster than trials that may provide a more boring result. So when you look at the body of evidence, you can see those two combined, and you get a sense, a maybe more balanced sense of what's going on. But when you just look at the early studies, you may be looking mostly at those who have captured the imagination of the editors, and as a result, you consume them faster, and it will be a misleadingly positive, misleadingly optimistic view of therapies. It may be that the initial studies just produce large effects by chance, something that you can read more about if you search under the Proteus effect, and that may be misleading. It may be that serious adverse effects are rare and only come up after prolonged exposure, so they will be mostly absent from early studies. And of course, one thing that, again, I repeat is rare is the problem of fraud, but sometimes it takes a while for revelations of fraud to become available, and you have to wait. I want to finish, and I know I'm a little bit behind, but I want to finish by pointing out that in my field there's a particular debate or a particular issue that is pertinent to our discussion. Here's a big trial, 7,000 patients with diabetes, empagliflozin versus placebo. Empagliflozin is a medicine that makes you pee sugar, and as a result lowers your blood sugar, lowers your blood pressure, helps you with weight. And they looked at a composite endpoint, death, non-fatal MI, non-fatal stroke at 2.5 years. Here are the results. A difference of 1.6%. That will, suggest a small difference. If you look at the confidence interval of the hazard ratio, 0.99, so it's a confidence interval that kisses the line of no difference. The components seem to have a similar representation of events, and a very different distribution of their hazard ratio. Becomes more imprecise, of course, as the events become rare, but mostly the difference in mortality in the composite, is mostly a difference in cardiovascular deaths. There is no dose-response relationship. There are perhaps drugs that may have been associated with increased problems in the placebo arm. There's a meta-analysis of small trials that is consistent with this result. And the question for us is it real? Is it a class effect? Should we act on it and give this medicine like we give statins? Should we wait until revelations of adverse effects or other studies come up? And these will be the kinds of things that we'll have to be worried about. Finally, this is, if you want to just remember one thing of our talk, is that you should suspect spin if you have early evidence at apparent low risk of bias, reporting small or larger than expected effects. In those cases, spin is a potential explanation for what you're seeing. Thank you for your attention.